Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host, Rachel Frank, a sports and shoulder surgeon at the University of Colorado in Denver. Rachel, how are you?
Doing well, thanks, Pete. How are you today?
Oh, I'm doing great. Before we get started, I should mention that the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, the University of Colorado, or the institutions of any of our guests. Today, for our 40th episode, we have something special. We invited Dr. Laurent Lafosse of Annecy, France, onto the podcast. Although many listeners will be familiar with Dr. Lafosse, I'd like to offer a brief introduction. Dr. Lafosse, who serves as director of the Alps Surgical Institute in Annecy, has been an innovator and educator within shoulder surgery for decades. Although he's made innumerable contributions to the field, he's become best known for his advanced arthroscopic techniques that he has shown worldwide in his meeting, which remains one of the most popular shoulder meetings in the world internationally. These techniques include the arthroscopic suprascapular nerve decompression, the arthroscopic Latarjet, and the arthroscopic latissimus transfer most recently. While not all surgeons have had the skill or courage to follow in his footsteps, these advances in surgical technique have dramatically changed our approach to more common problems and have had ripple effects within the field. And for that, we all owe him a debt. Laurent, welcome to the podcast.
Thank you. Thank you for inviting me. It's a great honor being here.
Well, we're very glad you were able to join us. Laurent, I want to start by asking you how you came to be a shoulder surgeon.
I was originally a general orthopedic surgeon. I even did a lot of general surgery, including vascular surgery, and I started to do more upper limb extremity, as well as I developed my spine surgery initially, and then I got my microsurgery diploma because I was doing a lot of free implants of hands and fingers and all this stuff. Then I moved to I developed the shoulder field because that field was really empty. And when I started my practice in Annecy in 1989, I was a fellow in Paris, and I was one of the interns of Paris University. And when I moved from Paris to Annecy, I was 33, and then I was a surgeon for upper limb extremity, spine, and shoulder. And then with time, I developed more and more the shoulder, and then I stopped performing spine surgery in 2000, and then I stopped performing reimplants of fingers a few months ago.
A few months ago, so up until just a few months ago, your practice was still including reimplantation.
Yeah, not as often as what I used to do, but I perform more than 250 reimplants in my life. One day I calculated how many hours I spent on surgery, and it's this very famous book about the outliers, and it says that 10,000 hours are necessary to be at least somebody who has a minimum level. I think that I've performed more than 45,000 hours of surgery in my life. So it's true. I did a lot of surgery, and the shoulder was really a passion. I started to work with Goutelier, Didier Pat, all these names that you know. And in spine surgery, I used with Wakami, who was the inventor of the screw in the pedicle of the vertebra. I had a chance to know all these very famous people, and they were my mentors. So that was great for me.
45,000 hours is quite a lot. I think our younger listeners, especially our residence fellows and newer to practice surgeons, can really listen to that and see what it takes to truly become a master. How did you ultimately settle in Annecy? Of all the places you could have gone, what made you choose Annecy? And you've been there for so long. What has kept you there?
Two major reasons. I would say three major reasons. The first one is that Annecy is where I met my wife, and that was the most important. The second reason is that when I met Annecy, I was 14 years old, and my will was to become a water skier teacher on the lake. It's the most beautiful city in the world. And when you have been in Paris your whole time, and then you discover such a city, and then you would love to live there. And the third reason is that the field for shoulder and for hand surgery and for spine surgery, microsurgery of spine was empty. So I had to create all these things for my private practice, and I loved to be the one who would, be free to develop his ideas and his techniques somewhere. But Annecy is in the middle of nowhere. Now it's very well known by tourists because it's close to Geneva and it's a fabulous city. But in terms of there is no university, it's a very small town. So there were not really big interests. And I didn't want to become professor and to have a public career. I wanted to develop my own ideas. And that's what happened.
Now, I remember speaking with you previously. You still water ski almost every day too, right? In the mornings.
I did, and I did a few minutes ago. I just stopped water skiing about an hour ago.
Oh, I'm
So
sorry we
yes,
had to interrupt your water skiing.
no,
Um,
no, you did not. But let me tell you that I may go to water ski a second time today. Today I'm not
oh, good.
working, so it's good. No worries. Yeah, I still water ski, of course. It's still my favorite sport. I'm 65, but nevertheless, I'm not doing tournaments anymore. But I'm still moving forward.
That's great. I wanted to get into some of the kind of specific things you've contributed to the field. One of the
Right.
earlier ones was your classification of subscapularis tears, which is still one of the most widely used, and your paper on subscapularis tears is a landmark paper in our understanding of that particular tendon. Tell us about the genesis for that project. How did you become interested in that?
You would be very surprised to know that the genesis of this idea comes from Didier Pat himself. Before Didier Pat died, he was very sick, and I used to be his assistant, working with him in his private clinic, just helping him to open and close his patient. And he was, of course, at that time not doing any open surgery or any arthroscopic surgery. That was back 1988 exactly. And he told me subscap is certainly the most important muscle for stabilization of the center of the head in the shoulder. But the issue is that we don't know what is the best approach for subscap repair in case of huge retraction. And that idea remained on my head a long, long time. And after, when I started to do my practice in NC, I started to perform arthroscopic surgery like everybody, and I started to develop the intra-articular and the extra-articular um, arthroscopic surgery. And then around 1985, I already performed a few subscap repair. But my English is not very good. It was even uh, poor, much more than today. And so I tried to publish all this subscap repair arthroscopically. I submit publication, and it didn't work. So I started to uh, be known about arthroscopic subscap repair once the first publication was done by Steve Burkhardt. And as I performed some live surgeries, then the people saw me uh, repairing the subscap. That was really the first step for subscap arthroscopic repair. The second step regarding classification is that something was missing in the classification for rotator cuff tear. And supraspinatus, infraspinatus was classified with the PAT classification, but nothing was moving for the subscap. So what I just did is just to build an equivalent of what Didier Pat did for supraspinatus, but for subscap with stage 0, 1, 2, 3, 4. The only difference is that stage 4 was something a little more based on the uh, upper and anterior migration of the humeral head, which is in contact with the cricoid process, which is not something which is part of the PAT classification for supraspinatus. And there is no upper migration on the PAT classification for supraspinatus and infraspinatus retraction. So that concept led me to the 4D classification. Maybe you know it, Peter. And the 4D classification is something which include the PAT classification, my classification for subscap, the bicep statement, and the fourth dimension, which is the time and pre-op, per-op, beginning of the surgery, at the end of the surgery, and post-op at 6 weeks, 3 months, 3 years, whatever. So that is it's part of the global picture of the rotator cuff tear, including the subscap classification.
Now, I have to imagine that as you approach the subscapularis arthroscopically and did more and more of those tears, especially retracted tears, you must then have gotten the idea for the arthroscopic Latarjet. Is that kind of where you began to develop that technique? When did you start with that? How did you get this idea?
Absolutely, you're correct, Peter. The fact that I started to repair the subscap and that I moved from intraarticular to extraarticular, and I started to move outside the bursa, the subacromial bursa, toward the subcoracoid bursa, and then you start to see the anterior face of the subscap. And we didn't speak about it, but I used to perform a lot of open plexus repair when I was in Paris with Duparc, Calno, and all these people. And I still perform a few plexus repair here in Annecy at the beginning of my practice. And maybe I did close to 1,000 plexus repair. So I used to be very, you know, I used to be on this area of the plexus. So the plexus was not a problem for me. And I started to dissect the plexus when I was on these subscap tears, retracted subscap tears. So that was exactly what Didier Pat told me maybe 10 or 15 years before. Please find an approach for subscap repair. And the arthroscopic approach is certainly the most accurate and the less dangerous approach compared to the open one today. So that was the beginning for me of the exposure of the entire coracoid. So my when my friend Gilles Valch told me I will start to do arthroscopic stabilization for instability the day you will do an arthroscopic Latarjet, then I just in 2000 started to think about how to perform an arthroscopic Latarjet. And by exposing the coracoid, exposing the plexus, exposing the subscap anterior part, and then most of the steps were already done. So the only issue was to find the instrument. And my first arthroscopic Latarjet was in December 2003 when a 50 years old gentleman asked me to repair his instability of the shoulder. But as he was doing a lot of parachute, he didn't want to have any scar on his shoulder. So I told him, I can't do that arthroscopically, but you will be the first one. And he said, okay, so you will succeed on the first one. And he had no subscap. So that was my first Latarjet. It was a Latarjet for somebody who had no subscap and didn't want any cut on his shoulder because he knew that that would be a problem to get his license to keep on flying. So that's the history of the first Latarjet. But I only had at that time a screwdriver, a shaver, a burr, and an electrode. That's it.
Wow, what a start to such a revolution of performing that procedure. And I think, a lot of young surgeons and more experienced surgeons learn about these techniques at your meeting. And your name and your practice have become synonymous for your shoulder meeting. I actually remember going with Dr. Romeo to your meeting when I was a resident, and my whole concept of orthopedic meetings changed. To see you bring patients up to the stage, examine them, have expert surgeons from around the world examine them, and then all of you guys upstage kind of talk to each other and agree and critique each other right in front of hundreds, if not thousands of surgeons, and then have them undergo surgery the very next day. It was incredible. It changed for me what I thought an orthopedic meeting could and in fact should be. When did you start this meeting? How did you get the idea for this meeting, and how has it evolved over the last several years and decade?
Uh, that's a very difficult question. It's not a difficult question. It's an easy question, but it's a difficult answer. It's a long answer because that the idea, the aim of this is that I want to be transparent with everybody, with the patient, with the fellows, but even with the other surgeons. And I would say that the companies helped me a lot for that. And DePuy was the first company who really supported me, and JP Warner opened me the doors, and in US, as well as Gilles Valche opened me the doors in France. I was just a little surgeon in a little town in France in the middle of nowhere. But the fact that I show these people uh, what I was able to perform as arthroscopic surgeries, and then that made me become reliable for the companies first. And the word of surgeon would not be here without the word of the companies. And I always compare the surgeon with the pilots and the company with a car company. And if you race on a car, you need a car and you need a pilot. You need both, and they need to be a good team. This is what happened to me, and I had that chance. I was working a lot, and I thought that the best way to really show the people without hiding anything, to be neat in front of everybody, and then there is no contest, and the fact that you just show exactly what's the state of the art today. When you publish a paper, the paper takes at least 1 or 2 years to be written and to see the patient with a minimum follow-up. And then it takes 1 or 2 years to be published. So the day you read a paper, it's the state of the art about 4 or 5 years ago, which is something necessary. But it's like, on the toolbox, you need everything. You need a screwdriver, you need a hammer, you need a nail, you need a screw, and just this is only one of 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 the tools that we have on our toolbox. Live live surgery, live examination, discussion with the patient, of with everybody, every surgeon, the surgeon performing a surgery and another surgeon making the moderation, and another very famous surgeon. This is exactly the same thing as what happened in Woodstock, when somebody was singing and playing guitar, and another artist was there and just joining him to play guitar or to listen to him at the same time. So this is why I call this meeting the shoulder, the Woodstock of the shoulder surgery. And that is really based on the fact that we we don't teach the people, we just share our knowledge with the knowledge of the other surgeons, and we share it in front of everybody with a full transparency, in order to show every surgeon in the world who wants to attend that meeting what they can get from it. Maybe they will see an arthroscopic letarget and they say, we will never do that. Maybe they will see a shoulder arthroplasty and say, wow, what a very interesting trick, because this is the way to repair the subscap in such a way that I've never thought about before myself. And maybe something different, like the exposure, the setup of the patient, the way the retractors are placed. That is the aim of this, is just to help the surgeon to to give to bring a better care to the patient, to improve the quality of the patient care. This is not enough. Only sort of surgery live is not enough. Definitely, we need science. This is not science, it's technique. But technique is part of our job. It's one part of the chain of what we have to do.
One of the more interesting parts of the meeting, at least when I was there again a while ago, I mean, and the whole meeting was interesting, so it's hard to pick. I mean, it was life changing for me. Was when surgeons, are operating on your patients, and potentially something is not going as smooth as you want it to go, or someone is struggling. How do you, as you know, you're the lead surgeon, they're your patients, how do you decide when to step in, when to back off, when to encourage, et cetera, all while live in front of, you know, thousands of observing surgeons? I think one of the hesitations on bringing live surgery meetings in the States centers around this concept, around this idea. And so how do you make that call, especially when another expert surgeon is operating right next to you?
I would say number one is just to be very clear, to anticipate on the rules. And I'm responsible of the patient. And I always with full transparency explain to the patient that they will be operated by another surgeon, but I will be here and I'm close to him. And in any case, if the surgeon doesn't want to keep on going, and if he wants me to take over, and then I will take over. Or even more, if I feel that I have to take over, despite the fact that I'm in front of 1,000 people, I will take over and manage the surgery, because what we made after this meeting is the quality of the surgery and is the decision for the patient. It's the patient care. I'm not saying I'm better than the surgeon that I invite, but I'm just saying that my responsibility is that I should take care of my patient. That being said, when the surgeon performed the surgery, I'm close to him, like a pilot is close to the co-pilot when they take off, land, and everything. But if there is a problem, the captain has to be the captain and to decide. So this is what I'm doing. So when the co-pilot, which is the invited surgeon, doesn't feel well, doesn't feel good, or have a problem, or just make a mistake or break the humerus, that had happened once. By reducing an arthroplasty, one of my invited surgeons broke the humerus. Okay, what do you want to do? This surgeon, professor, said, okay, I would like to perform offline the repair of the fracture of the humerus. And then once it's done, I will show it to the people. Do you agree? Yes or not? I said, I agree. So he moved on. He made the repair of the humerus. He fixed the humerus. And then maybe 1 hour later, we show the humerus repaired and everything was fine. The second option is that the patient is still under control, despite the fact that there is a problem, by the invited surgeon. And the invited surgeon still feel good to keep on moving, despite the fact that there is a problem, and wants to show how to solve the problem live, which is something that already happened a few times. And he's the one who will decide if he wants to remain live or not. The most important is that the surgeon feels comfortable and that the patient has no, how would you say that, has no dead part or black, or the other side of the has no issue by being in live surgery. The fact that he's operated in live surgery should not influence the quality of the result. This is the key. So if the live surgery is a problem, we just stop the live surgery. If it's not, and then we keep on moving. Interestingly, I've been invited once in a country for live surgery, and I was supposed to perform an arthroscopic Latarjet. And the patient canceled at the very last minute. So they found another patient. But the control of the second patient was not as good as what the first patient was. So I just entered inside the shoulder. I saw the file of the patient. I said, okay, there is no x-ray with dislocation. Yeah, but the patient said he dislocated. And then, nevertheless, I entered the shoulder and I saw a normal shoulder. I was scheduled for an arthroscopic Latarjet. And I said, I'm sorry, I will not perform any shoulder surgery for this young lady. There is no need for arthroscopic Latarjet. And I just stopped my surgery, and everybody was happy because it's reality. This is what is reality. It's true. You cannot lie when you are live.
Yeah, I think for me, that's the piece that cannot be taught in a textbook or a lecture. And that what that whole concept of moving live, whether it's the physical exam or the operation, and making those decisions, that was the most game changing for me as a trainee. And I think about that meeting often, in my practice. So thank you for doing that and continuing to do that. I'm sure you have favorite memories from the meeting. It's probably hard to pick a favorite, but do you have a couple favorite memories that you can tell us about?
Wow, I have so many. Uh, I would say the one I just told you was one of the most interesting. Uh, Maybe another one uh, at the very beginning of the surgery. We start the surgery before the live transmission. And one surgeon one day was invited, and a very famous surgeon was just finishing to make the dissection, maybe a few minutes before the shoulder arthroplasty. And by doing the release at the upper part of the glenoid, at the posterior superior part of the glenoid with the blade of the scalpel, it just broke the blade of the scalpel at the upper part of the glenoid. But it was like 2-3 minutes before live transmission. And the time he had to show the arthroplasty was only 30 minutes for the glenoid. And he was supposed to show the glenoid only. So we performed the glenoid live with the blade still in. And then he finished the shoulder arthroplasty, and the blade was still in. And at the end of the transmission, we said, okay, now it's time to remove the blade. And the only way we could find the blade was to perform an arthroscopy. So we removed the blade arthroscopically after the live. But we told that story to everybody. So this is one of my best memories of the meeting at the very beginning. My first arthroscopic Latarjet in 2005, at the moment that nobody believed that it was possible. But I would say that my best memories, not one, but many, are the surgeries performed by seniors and wonderful people like Bassem El Assam, for example, who perform the tendon transfer, and all the other people who made tendon transfer arthroscopically, or all the people who perform the shoulder arthroplasty, and the fact that I learned so much by organizing this meeting. I learned so much from the people that I invite. And every time I invite people coming to Annecy to perform live surgeries, I learn, I learn, I learn. And it's a pity to see how much I have to learn still today. But it's certainly my best memory is to learn from the people around.
I wanted to talk to you a little bit about that process, the learning process. As you've described earlier, you've invented several completely novel surgical techniques. Many of our listeners are surgeons earlier in their careers who are learning new things. Certainly, surgeons who are later in their careers are still learning new things as they try new techniques and as our field changes. What advice would you give for surgeons as they approach a new procedure or something they've not done before, something that's novel to them?
I would say that this is very parallel to what sport is. Uh, as you mentioned at the beginning of your interview, you said I'm a water skier. What about the first time you try to do a new trick? If you try to do a new trick and you are not at the level of this trick, you will never succeed. I think that whatever you learn, the most important is to work and to work and to work. As we described before, I move very progressively from the shoulder arthroscopy to the shoulder endoscopy outside the box, then to the subscap approach, then to the coracoid approach, then to the plexus release, then to the arthroscopic Latarjet. And I think that if you move step by step by step, and then that is the way to learn. It should never appear difficult to you. You should always be trained to achieve and to do it. If you want to run a marathon in in 2 hours and 15 minutes. How do? You just train. If you want to play Rachmaninoff with the piano, you just train, work. The my chance was that I'm not gifted. And if you're not gifted, the only way to be able to do something is to work on it. Because when you start to do something, you cannot do it without your work. The people who are gifted, it's so easy for them. They don't have to work, but they don't succeed with long time. And I think that the, the fact that you are not gifted is certainly the best chance that shows you that you have to work a lot to be able to do on something. Now you can have a passion, an idea to invent something, and that is certainly the emotional side that you must accept inside yourself. Like every creativity is based on emotion, but with emotion, with no work, has no success. I don't know if I'm clear, but I hope I am.
As you've done that work, as you've progressed through this new technique, do you have a method for recording and analyzing the challenges? Do you have a book you keep? Do you have an organized way of doing that, or do you just progress organically through it?
I have my videos. I look at the videos. I look at the other people. I look at the way the other people are operating. And I think videos are certainly the most important things. And then I read. I read the papers. I prepare my lectures by reading, and my fellows are helping me a lot to read and to select the papers I should know before doing something. So uh, I I have no read any book of my experience. This is maybe something I will do in the future. I participate on a book for complication or arthroscopic surgery and on shoulder surgery, but I I may if I may finish a book that I started about subscap, and this is something that when I move back to what I've done, and then I move back to my videos to explain that I don't have any paper or any book that where I write something to keep on my ideas. My ideas are on my head, and there is nothing else.
Dr. Lafosse, your son's recently joined your practice. Tell us, how does it feel to have two generations of Lafosse shoulder surgeons in Annecy?
That's the best chance you may have in your life. When Thibault was 17, we sent him to US. He spent a year in US, and he got the SIT, and he was on the top 5 mathematics and English. So he had a chance to become engineer or businessman in US and everything, but he did not want to. He came back to France, and he said, I want to become a doctor. And then we had a fight during dinner, and I said no, because on that time it was really hard for me. And I said, no, you should really take this opportunity to be in US and to have a job in US and to be part of this. And finally he said, I don't know if it's because of you, against you, but I want to become a doctor. And then he wanted to become a surgeon. So the fight was over after a few hours, and then I saw him just I supported him by doing what he wants to do, and he became my fellow for 6 months, and he was exactly the same fellow as the other fellow, and he was good. He has good hands. He is working hard. He's okay, and I'm very proud and proud of what he's doing. And sometime I learned from him because he moved a lot around the world, and he learned a lot of techniques and tendon transfer with BSM and other microsurgery things in that he may not speak about when he's in shoulder meeting, but he knows a lot of double reimplants and all these things, or and that I when I do microsurgery with him, and then that's really neat because I learned so much, and I learned from him for the tendon transfer too. So that's very nice. It's and step by step, I may move away progressively, and I'm getting old, older than what I was 10 years ago, of course, but less old than what I will be in 10 years. But it's maybe time to let the next generation moving forward. So the fact that we do something together now and that we have an overlap, I would love that to continue as long as possible and to remain here because we have a perfect fit. We never fight. It's wonderful. I have a chance to have a very good surgeon, a good organizer, and I'm very proud of what he is doing. So that's the best chance you may wish yourself in your life.
Well, certainly that sounds wonderful, and certainly that's such a great reflection of your parenting, which is something we don't talk about often in our podcast, but certainly an important part of all of our lives. I wanted to ask you one other question we've asked a lot of our guests, but I think you may have a unique answer for, which is if you could have dinner with every person from history, who would it be and where would you have dinner?
Wow. I would say that dinner already happened once in my life. That was with Dr. Rockwood. That was just a few days. His wife was operated, his new wife, and she was not his wife yet because his previous wife died. And Betty met her, and that was a wonderful dinner because during the dinner he asked her to become his wife. During that dinner where only the four of us were here, Babette, Jane, and Dr. Rockwood. That was in Annecy after she had surgery. And that is certainly the best dinner I ever had with a relation, I would say, a business relation or a work relationship with friends. So something. Uh, that's a dinner that I will remain forever in my mind.
That is truly an incredible story. Dr. Lafosse, I can't tell you how much we appreciate you having you on the podcast, and your insights are invaluable. I know our listeners will really enjoy everything you've shared with us. I think we all owe you thanks as a field for the techniques you've developed and the ways you've changed our approaches to so many different problems. So thank you for your mentorship on the behalf of really our whole field, and also for coming to speak with us today.
Thank you so much. If I may say a last word to the people here, I really want to thank everybody around, but just don't overestimate the people who are famous. I'm just like everybody. I just work a lot, but I'm not better than anybody. I'm just somebody who has been working a lot and who wants to take care of his patients with a lot of transparency. And I'm really thankful for all the people who has been helping me and helping the field of the shoulder, and like you, Peter, and like all the young generation to keep on moving and to try to get the shoulder surgery better with a very good friendship spirit, which is the most important. Shoulder surgery should be a pleasure and with a high quality, but a pleasure. Thank you.
Well, I'll echo Pete and thank you so much for all that you've given us, given the field, given so many surgeons and their future patients. You have an ability to not only impact your own patients, but so many patients around the world. And that's a gift that will keep on giving for generations. Well, that's really all the time we have for today's ASES podcast. Again, we want to thank the one and only Dr. Lafosse for joining us. For all of our shoulder and elbow listeners out there, please don't forget to subscribe. And for Pete Chalmers, I'm Rachel Frank, and we'll see you next time.